Assalamu alaikum everyone. This is a lecture series that is composed of the core behavioral sciences lecture that we have to cover as per the Punjab Medical College curriculum. However, this can be applied universally anywhere. I will be starting from the lectures that were remaining in my actual lectures that I conduct, and then later on I will add in the previous ones. So today we will start from a lecture topic in section E of the behavioral sciences book that we have, and the title is drug use including alcohol and tobacco use. Acha ji, to start with, before we go into the different types of drugs that we need to cover, we need to know that what is it that the drug actually do to our body. जब हम एक ड्रग लेते हैं तो क्यों हमें एडिक्शन होती है और वो क्या मैकेनिज्म है, that we need to know. So for the purpose of your exam, you at least need to know that these drugs that we take, regardless of the type of drug, act on the dopamine pathways, and this is a pictorial diagram that you are seeing on screen, and please try to remember it if possible. And this is a typical dopamine pathway through which these drugs act, and they act on the reward centers, they cause pleasure and euphoria, and therefore there is a need or a craving to take them again and again to get the same effect. Okay, so as you can see that we can divide these drugs into three main types, primarily two types, and the third I'll talk about later. So either these drugs will depress our central nervous system, our respiratory system, our cardiac system, or it will excite or stimulate our central nervous system and respiratory system and cardiac system. So the drugs that depress our central nervous system or that cause slowing down of our central nervous system are the opioids such as heroin, morphine, codeine and oxycodone, as well as alcohol, benzodiazepine and barbiturates. And the drugs that excite or stimulate our central nervous system are cocaine, amphetamine, caffeine, nicotine, and recently ice or crystal meth. There's a third category of drugs which we call as cannabis, which includes marijuana, hashish, bhang or churs, which is not an exact stimulant or depressant, but it enhances the state that a person is already in. So it is a third category that you need to know of, and I would want you to know at least the basic names of the drugs or the substances that are mentioned here on the slide. So why is it that we take drugs? ऐसा क्या होता है या what happens that either us or the patient or our friends kind of oscillate towards or tilt towards taking drug, and then what is it that keeps them going? So there are a few factors that I have enlisted. Primarily when there's this young age, adolescence, there's a lot of peer pressure that comes in. It is an escape from reality, and it's a maladaptive coping strategy, which is number 7th. So basically you are undergoing certain amount of stress, and this is your way to cope with that stress, which of course is unhealthy way. Then maybe in order to avoid physical pain, and a lot of doctors and pharmaceutical experts hook on their patients onto certain medications, then they become addicted to them. Then the other factors could be maybe to seek thrill and for adventure, or even for imitation purpose. When you see somebody famous doing drugs, you might end up doing it also. DSM-5 has this criteria of substance use disorder. As you can see that it is slightly different from DSM-4, which is the old diagnostic manual, and it was called substance dependence. So there was something called substance abuse and something called substance dependence. So let's not go into that confusion. The new diagnostic criteria simply recognizes the problem as substance use disorder, and there's a checklist that you can see in front of you. If you want, please pause the video and kindly look into all these items, and if 2 to 3 of these items are present, then it is a mild substance use disorder. If 4 to 5 are present, then it is a moderate substance use disorder, and if more than 6 are present, then of course it's a severe substance use disorder. So you just need to remember one clinical name, that is substance use disorder, and you need to know briefly of all this checklist. These are the questions that we ask in our patients in order to diagnose. So let's briefly start with smoking. An estimated 40% males and 10% females in Pakistan and presumably in the rest of Southeast Asia, with varying figures geographically, are smokers, and the number sadly is increasing day by day. Tobacco, we need to recognize, kills nearly 6 million people each year in the world, of which more than 600,000 are those who actually don't smoke themselves, but just because they were sitting with others who used to smoke, they would end up being killed also. So the take-home message is that unfortunately we don't take this issue seriously, but we need to really strive and do our best to get rid of smoking as a menace in the society. Okay, so cannabis is another group that I initially talked about, and now I will go in a bit of detail. Cannabis is basically derived from the plant cannabis, and it has its particular active component, and for the sake of undergraduate I don't want to go into a lot of detail of that. But what you need to know is that common local market names of cannabis are marijuana, weed, churs, bhang, ganja, and hashish. And these are different formulations of varying potency, but all of these come under the category of cannabis and are made from that same plant. So a lot of people think that cannabis is not that harmful, and that is unfortunately a misconception. It could cause distortion and severe distortion of perception and judgment. It also leads to amotivational syndrome in students, in which they kind of lose their motivation to do anything and they become extremely laid back. Cannabis is definitely known to cause psychosis as well as mood disorders, especially manic-like symptoms. And there are a lot of cases, there are a lot of studies, this is now a lot of data which suggest that cannabis can actually properly induce schizophrenia. So it is not as benign as it was initially thought to be. Now the other category which comes under CNS depressant, if you go back to the slides where I have classified them, is opioids. Opioids is made from the poppy plant. Opium is another name that we commonly use when we talk about opioids, and generally it is divided into medicinal medications that are used in hospitals or clinic to treat pain, such as morphine or codeine or oxycodone, and then non-medicinal medications which are used for abuse purpose and for recreation purpose, such as heroin. And there are certain injections also, injections such as Kins injection and pentazocine injection, that are opioids in nature. They are given to treat pain, but each year thousands of people start taking these injections and then they get addicted to it. So another way of taking opioids is called affione, which are small rolled balls that are then kept in mouth. So all these names, whenever you hear of them or whenever you see a patient who's using them, you need to know that this falls under the category of opioids. An opioid is taken by various routes, and the most risky route is the IV drug use, because it leads to needle sharing. Then there's a high risk of hepatitis and HIV. So how do we manage anybody who comes to us, whether he's taking opioids or he's smoking or he's taking cannabis or whatever drug it is? Because the list is extremely enormous, and I really don't have the time on this particular video to go through each and every drug. But when it comes to management tools, primarily there are three management tools. First is a good history. You need to take a very comprehensive history. Please look at all the stressors that might be causing them to either start the drug or to maintain it or to keep taking it. Then what is their expectation? Do they want to quit? Do they want harm reduction? Use it on a good biopsychosocial model and also assess their motivation to quit. Second step is then offering counseling and support. And then of course, if they are taking for a long time or in higher doses, or if they have developed a moderate to severe substance use disorder, then we need to take professional help and refer them to psychiatrists or addiction specialists. So withdrawal is usually those physical and psychological symptoms that we have once we stop taking these medications. If we were addicted to these medications or these drugs and suddenly we stop taking them, our body could experience certain physical or psychological symptoms such as tremors, chills, cramps, cognitive issues, confusion, and emotional problems. Now with alcohol and benzodiazepine, their withdrawals could also lead to seizures in severe cases. Why? Because they are seen as depressants. So as soon as you take off that depressant effect, suddenly the mind could become extremely excitatory and go into a seizure. Similarly, opioid withdrawals have altogether a different set of withdrawal symptoms, and this is very classic of opioid withdrawal. So if you see certain symptoms in your MCQs or in exam setting or during Viva, it should click to you that they're talking about opioids. Now these withdrawal symptoms are diarrhea, runny nose, runny eyes, dilated pupils, and body aches. Nicotine withdrawal usually has more psychological withdrawal effects. With a few self-help advices, I will now end the lecture. First of all, it is to distract or delay the urge to take a particular drug. And if you do feel like your dopamine loop is really craving for that drug, maybe we can think of feeding it with something else, maybe an extreme sport, something more thrilling, a sports activity, music, or something else that feeds that dopamine loop, and you don't go into an unhealthy mechanism. Really focus on relaxation, having a positive frame of mind and commitment. And last but definitely not the least, never ever judge a patient or a friend. Don't follow the moralistic model when it comes to drugs. Please look at it from a medical point of view. If somebody is using drugs, there comes a time because of the neuroplastic changes in their mind that they really can't get rid of that habit. And it is the need for us to remain empathetic and to help them in their journey. Thank you, and I'll definitely come back with a more detailed lecture on this particular topic.